This recorded lecture will be going over Chapter 42, the integumentary system. The skin is attached to underlying structures by the subcutaneous tissue. Cell growth occurs from the bottom of the epidermis and pushes cells above to the surface, where they eventually die and slow off or are washed off. This layer is called the stratum corneum. A hair consists of a shaft and a root made up of dead, keratinized epithelial cells. Fibroblasts that produce new cells to heal the skin are contained in the dermis. The skin acts as a protective covering over the entire surface of the body. The skin helps regulate body temperature by dilating and constricting blood vessels and by activating or inactivating sweat glands. Sebaceous glands secrete sebum that function to keep hair and skin soft and pliable. Sebum also inhibits bacterial growth on the surface of the skin, and because of its oily nature, helps prevent water loss from the skin. Loss of collagen fibers in the dermis will make the skin increasingly fragile with age and slower to heal. Thin skin and decreased sebaceous activity will reduce temperature control and lead to an intolerance of cold and a susceptibility to heat exhaustion. A reduction in melanocyte activity increases the risk of sunburn and skin cancer. A decrease in the numbers of melanocytes at the hair follicle causes gradual loss of hair color. The skin is the first line of defense against invasion by pathogenic bacteria living in the environment. If very large areas of skin are destroyed, as in an extensive burn, fluid and electrolyte balance will be disturbed. Protein and body heat are lost from the burned areas. The skin will also reflect systemic diseases. Most of the recognized and named skin disorders arise from some pathology in the skin itself. The remainder are manifestations of systemic disease. Skin disorders may occur from immunologic and inflammatory disorders, proliferative and neoplastic disorders, metabolic and endocrine disorders, and nutritional problems. Physical, chemical, and microbiological factors will also damage the skin. Many patients with dermatologic disease are not hospitalized and will be seen only in healthcare providers' offices and outpatient clinics. Experts do not agree on what frequency of bathing is best for health, but most do agree that it does not need to be daily. Hospitalized patients may be at risk for skin breakdown due to multiple factors. Keeping the skin clean and dry is an important nursing intervention. Using a 2% chlorhexidine gluconate was found to significantly decrease the incidence of healthcare-acquired infections, but many patients could not tolerate the CHG, and it has since been abandoned as a long-term solution. If the skin appears dry and scaly, frequent bathing with soap and hot water will only aggravate this condition. People with oily skin will need to clean their skin frequently with a liberal amount of soap and water, and will need to apply fewer or no additional oils to the skin. Severe nutritional deficiencies can lead to skin breakdown and the development of sores and ulcers. Dehydration causes loss of skin turgor and predisposes to pressure ulcers. As we grow older, our skin undergoes certain changes that easily lead to irritation and breakdown if proper skin care is not given. The oil and sweat glands will become less active, and the skin tends to become dry and scaly. It also loses some of its tone, becoming less elastic and more fragile. Assist the older adult patient to establish a regular routine of massaging oil, cream, or oily lotion onto the skin. Several environmental factors can have a different effect on the health of the skin. These would include prolonged exposure to chemicals, excessive drying from repeated immersions in water, very cold temperatures, and prolonged exposure to sunlight. Some of these are occupational hazards. Overexposure to UV rays of the sun can seriously and permanently damage the superficial and deeper layers of the skin. The damage results in severe wrinkling and furrowing, as well as a loss of elasticity, and the skin assumes a tissue paper transparency. Solar damage can also result in malignant changes. UV rays from the sun have long been known to be carcinogenic. Although sunburns are particularly harmful, it is the normal daily exposure of unprotected fair skin to sun that will cause long-term damage. On page 985 within box 42.1, you can read about different risk factors for skin tears in older adults. Good nursing care includes protection of the skin and prevention of skin tears. A skin tear is a potentially preventable traumatic wound that occurs primarily on the extremities of older adults due to age and debility. The wound occurs as a result of lack of caution when handling, friction alone, or shearing and friction forces that separate the epidermis from the dermis, or separate both structures from the underlying tissue. Those individuals who require total care are at the highest risks. However, when a skin tear is discovered, steps for its management are as follows. Gently cleanse the skin tear with saline. Allow the area to air dry or pat gently and carefully. If the skin tear flap has dried, remove it using scissors and sterile technique. If the skin tear flap is viable, gently roll the flap back into place using a moistened cotton tip applicator. If bleeding has stopped, a silicone-coated net dressing is preferred. If bleeding continues, apply pressure and then dress with alginate and a secondary dressing. You should manage this in the same way as a skin graft. Assess and measure the size of the skin tear and always document assessment and treatment. The dressing should continuously cleanse the wound, conform to the wound, absorb exudate, and keep the wound bed moist and reduce pain and discomfort. Extra padding for the involved extremity can help prevent additional injuries. Removing a sample of tissue is known as a biopsy from a skin lesion, and this can typically be performed with a local anesthetic. It can be done by shaving off a top layer of a lesion that rises above the skin line, known as a shave biopsy, by removing a core from the center of its lesion, known as a punch biopsy, or by excising the entire lesion, known as an excisional biopsy. Skin biopsy is used to differentiate benign from malignant lesions and to help identify the causative organism in bacterial and fungal infections. No special patient preparation is necessary beyond a simple explanation of the procedure and its purpose. After the procedure, the patient is given instructions for the care of the biopsy site. After 12 to 24 hours, the bandage should be removed, the incision site should be cleaned with soap and water twice daily, and a bandage reapplied after each cleansing. When a bacterial, viral, or fungal infection of the skin is suspected, culture and sensitivity tests can be used to identify the causative organism and the drug that is most appropriate for treating that specific infection. Once the organism has been cultured, colonies can be tested for sensitivity to certain anti-infective agents. Various stains and solutions are used to prepare the skin, hair, scales, or nail material for study. These tests can identify fungal, bacterial, and viral organisms. To check for organism infestations, scrapings are suspended in mineral oil and examined under a microscope. Inspection of the skin is one of the principal means by which skin lesions are diagnosed. To facilitate the diagnosis of certain kinds of skin disorders, special lights may be used by an examiner. A cold light is one in which light is transmitted through a quartz or plastic structure to dissipate heat. Because there is no danger of burning the skin, the cold light can be applied directly to the skin to illuminate its layers for visualization of malignant changes. A wood light is a specially designed UV light. This special light is especially useful to diagnose fungal infections of the scalp and chronic bacterial infections of the major folds of the skin. Under a wood light, fungal lesions and erythema are fluorescent. Diascopy uses a glass slide or lens pressed down over the area to be examined, blanching the skin and thereby reducing the erythema caused by increased blood flow to the area. The shape of the underlying lesion can then be revealed. When a rash is suspected to be of an allergic nature, one of three methods is used to identify the responsible allergen. Test chemicals or substances are introduced to unaffected skin, usually on the forearm or back, by superficial scratches or pricks in the prick testing. In patch testing, the allergen is applied to the skin in the form of an adhesive patch and left for 2 days. The allergen could also be introduced by intradermal injection. If a localized reaction producing a wheal occurs, the test is positive. Check to see that the patient has signed an informed consent for any invasive procedures like a biopsy. Check for allergies to the anesthetic or skin preparation solution. Properly label any specimens and send them to the laboratory. Diagnosing skin disorders requires a thorough history to identify factors that predispose a patient to skin disease or factors that cause some types of skin disease. Many drugs can produce skin eruptions in certain individuals. Itching and pain are the most common complaints. If the disorder is caused by an allergy, the patient may also complain of shortness of breath, cough, or some GI symptom. A thorough inspection of the skin under good lighting is essential. The patient should don a gown that allows access to all areas of the skin. Seborrheic keratoses are common in older adults. They can appear as a wart-like, greasy lesion on the trunk, arms, scalp, and sometimes the face. They are not a cause for concern. Darkly pigmented people will have areas that are darker than other parts of their skin. This is caused by hormonal influences. The darker areas are typically the nipples, areola, scrotum, and labia minora. This is true among both African Americans and Asians. When the skin of a darkly pigmented person is damaged, scar tissue may hypertrophy, forming a keloid. If an African American child has malnutrition, sometimes their hair will turn a coppery red. The skin should be lightly palpated to detect changes in texture and surface elevations. Palpation also is used to detect pain, areas of increased warmth, and tenderness. Skin turgor is assessed by lifting a fold of the skin on the forearm, chest, or abdomen between 2 fingers and seeing how fast it falls back into place. Skin that takes longer than 1 to 2 seconds to return to place is known as poor skin turgor, and this indicates dehydration. Skin assessment is performed during every shift on immobile patients, noting the condition of the skin over bony prominences. Once every 24 hours, usually during a bath, the skin can be totally assessed. When a reddened area is found, it should be checked for blanching. Simply press gently in the center of the area to see if it turns from red to white or to a paler color on darker skin. Blanching usually indicates that the redness is temporary and will resolve when the pressure on that area is relieved. Planning of the daily work schedule should include consideration of the time necessary for dressing changes, soaks, special baths, and other skin treatments. Different types of skin lesions and pictures of them can be seen on page 989 within Table 42.1. Some general rules when caring for patients with a skin disease may be helpful as a guide until specific orders have been obtained. Bathing with a soap is typically contraindicated in all inflammatory conditions of the skin. Dressings covering the skin lesions that have been applied by a healthcare provider should not be removed when the patient is admitted unless there are specific orders to do so. Do not attempt to remove scales, crust, or other exudates on skin lesions until the provider has had an opportunity to examine the patient. Observe the skin very carefully at the time of patient admission and record any observations on the chart. Avoid excessive handling or rubbing of the skin against sheets and bedclothes when changing the bed. And lotions or other skin products should not be used on the skin unless the provider has approved their use. Once the provider has determined the type of lesions present, specific treatments will be ordered to relieve the patient's symptoms and promote healing. The 2 most commonly used treatments are special dermatologic baths and wet compresses or dressings. Although most skin diseases are not contagious, you should be careful to observe the rules of cleanliness and standard precautions when caring for any patient with a skin eruption. Special care is needed to prevent spreading of infection from the fluid in all pustules and in the vesicles of fever blisters and cold sores. Among the agents that have been added to the bath water are sodium bicarbonate, sodium chloride, cornstarch, oatmeal, medicated tars, oils, potassium permanganate, and special bath preparations. When the patient is removed from the medicated bath, the skin should be dried rather than patted or rubbing. This applies to a regular bath as well. If medication is to be applied locally, it should be put on as soon as the bath is completed to keep pruritus at a minimum. Medication is applied in a thin layer unless otherwise ordered. The medicated bath has a very soothing and relaxing effect on the patient and also helps relieve itching and burning commonly associated with skin diseases. Bed linens and gowns used for patients with severe skin disease may need special laundering to eliminate all traces of soap. If the patient is to be cared for at home, vinegar may be added to the rinse water to neutralize the soap. Only detergent without perfume or other additives should be used. Dryer sheets should not be used because they contain chemicals that often cause skin problems. New clothes should be washed before wearing when the skin sensitivity is a problem. Wet dressings may be applied to the skin in various ways. The two general types used are open dressings and closed dressings. Open compresses must be changed repeatedly and are never allowed to dry. They usually need to be re-moistened every 20 to 30 minutes. This type of dressing can be used when the dermatologist wishes to have air circulating to the skin lesions. Closed dressings are thoroughly soaked with the prescribed solution and wrapped with an airtight, waterproof material. Many skin lesions are treated by directly applying medications to the surface of the affected area. This method is called topical therapy. Lotion, cream, ointment, powder, or gel can be used. Evaluation of treatment and nursing interventions for skin disorders is based on improved appearance of the skin, absence of signs of infection, relief from itching and pain, and signs of healing. Many skin disorders are slow to respond to treatment, and patience is required on both the part of the patient and you. A major part of evaluation is to determine that treatment is not aggravating the condition